Hi, my name is Molly Mazenko, and for my presentation, I will be talking about CAR T cell therapy and how it is being used to treat cancer. Before getting into the heavy science, I thought it would be important to discuss the history of how this treatment came to be. More than a century ago, surgeon Dr. William B. Coley discovered that it was possible for the immune system to be triggered to shrink tumors. Despite this important observation, immunotherapy took a backseat to chemotherapy during World War II. During this time, a U.S. naval ship sank, and the sailors on it developed pancytopenia as a result of mustard gas poisoning. Nitrogen mustard was then heavily studied and screened, later receiving FDA approval for use as a chemotherapy drug. As time went on and the scientific community gained a deeper understanding of the immune system, immunotherapy became a more studied and developed treatment method. Two types of immunotherapies in particular have shown immense promise. They are immune checkpoint inhibitors, which are primarily used in solid tumors, and adoptive cell therapy, which is primarily used in hematological cancers. They function to take the brakes off and push the pedal of the immune system. CAR T cell therapy is a type of adoptive cell therapy. This is just a timeline of CAR T cell therapy and all the progress made from its discovery to FDA approval. It started in the 1960s when the preventative role of adaptive immune cells in tumor expansion was discovered, and its use in clinical settings continues to progress. Most recently, CAR T cell therapy has been approved by the FDA for use in treating follicular lymphoma. There are currently 6 FDA-approved therapies on the market, with more in the works. They are often used in cancers that have relapsed or have not responded to other treatments, specifically aggressive non-Hodgkin's lymphoma, mantle cell lymphoma, follicular lymphoma, multiple myeloma, and B-cell acute lymphoblastic leukemia. So, what exactly are CAR T cells? Well, CAR stands for chimeric antigen receptor. CARs are synthetic, genetically engineered receptors that are made to bind to and target cancer cells that have a specific antigen and then destroy them. They are chimeric because one receptor has two functions: antigen binding and T cell activating. CAR T cells, engineered using the patient's own blood, are currently being used as a treatment for cancer and are considered a living drug. Our immune system depends on T cells to fight infections and diseases, but oftentimes, in the case of cancer, the immune system doesn't release T cells in time, effectively, or at all. This is where CAR T cells come into play. The engineered receptors are capable of adhering to the tumor cells and effectively kill them off. Here's a quick video that walks through the basics of what CAR T cells are, how they're made, and how they work.
At LLS, we always say that beating cancer is in our blood. It's a phrase that captures the heart and soul of what we do. But what if your own blood could actually be turned into a meaner, leaner, cancer-beating machine? Well, that's what doctors and researchers are doing right now with something called chimeric antigen receptor T cell, or CAR T cell therapy. To understand it, we need to start with T cells, a type of white blood cell that patrols our bodies for signs of disease. See, all cells have protein fragments called antigens on their surface. Some antigens are tumor-specific, meaning they're specific to certain cancers. And it is these tumor-specific antigens that ultimately alert your body's immune system, specifically your T cells. See, T cells have receptors on their surface that are uniquely designed to latch onto antigens of cancer cells. They then kill the harmful cells by injecting them with toxins. It's a pretty amazing system when it works. The trouble is, cancer is smart. Cancer cells can disguise themselves so our T cells don't recognize them as foreign. And when that happens, the cancer grows. leaving one of your body's most powerful defenses, well, kind of powerless. So researchers asked themselves, what if we could reprogram a person's own T cells to break through cancer's defenses? And that's what CAR T cell therapy is all about. In a nutshell, the doctor takes out some of your own T cells and sends them to a lab. The laboratory technicians turns them into supercells, CAR T cells. They do this by modifying the new CAR T cell receptors to recognize your specific cancer and make those receptors, well, more receptive to its antigens. The new cells are reproduced a few million times and then frozen so doctors can begin treatment when the time is best for you. Before you're able to get your new CAR T cells, you'll be given something called lymphodepleting chemotherapy, which will make room for your new supercells. Then, when it's time, your doctor will introduce the new and improved T cells back into your body. The good news is that they start attacking the harmful cells right away. The bad news is that the therapy has a high likelihood of causing side effects and making you sick. Many patients experience symptoms typical to a bad case of the flu. Patients also report nausea, dizziness, and loss of balance, among other symptoms. And make no mistake, in some rare cases, patients can experience more serious side effects like confusion, seizures, and even stroke-like symptoms. Your doctors will want to monitor your condition, so they'll likely require you to stay near a hospital or perhaps even check into one. But for many patients, these side effects are temporary and can be managed with medications or other procedures. What's more, researchers are making great strides in controlling and reducing those side effects. So what happens after the sickness passes? Well, this is the really good part. These stronger and faster CAR T cells just keep reproducing in your body for a long time after the infusion, continuing to fight the cancer if it returns. And in many cases, they continue to work long after a patient enters remission. Right now, this therapy is typically only given to patients with specific types of blood cancer who have not responded to common cancer treatments. And only your doctor can tell you if this therapy is a real option for you. But while the results are early, they're incredibly promising. And encouraging studies for other types of blood cancers are moving forward at great speed. As beating cancer is in our blood, but the key to beating your cancer might just be in yours.
The most simple, basic constituents of chimeric antigen receptors are the ectodomain, endodomain, transmembrane, and hinge. The ectodomain, also referred to as the extracellular domain, is usually a BCR fragment that is located outside of the cytoplasm and is the extracellular target binding site. This is the most important part of the CAR T cell, and it is integral for target antigen specificity. The hinge region, or spacer, plays a big role in T cell expansion and specifically cytokine signature. Depending on the length of the spacer, there can be a CAR or innate immune response activation that can mess with the efficacy of the process. The transmembrane domain functions as a path for signals to travel from the extracellular to intracellular environments. Finally, the endodomain is the functional end of the chimeric antigen receptor. This means that it has segments of signaling molecules that are necessary for T cell activation. All of these components of the chimeric antigen receptor play vital, important roles in the proper functioning and efficacy of the treatment. Because there can be so much variability in each part of the structure, and some studies show conflict between what is ideal and what is not, there is currently no optimal configuration of the CAR T cell. This quick video helps to simplify what I just stated about the structural aspects of CAR T cells and what their purposes are.
In the previous video, we realized what chimeric antigen receptor T-cell therapy is and how it works. Now we are going to take a closer look at chimeric antigen receptor, also called CAR. CAR consists of three domains: extracellular domain, transmembrane domain, and intracellular domain. Extracellular domain is a single-chain variable fragment, or SCFV, derived from the antigen binding region of the monoclonal antibody. And transmembrane domain is the portion the CAR anchored to the cell membrane. The last one, CD3-zeta intracellular domain, which functions as signaling portion of T-cell receptor. CARs are able to deliver a primary activation signal through CD3-zeta chain. By incorporating additional signaling domains, CARs now have evolved to third generation. With different signaling domains such as CD28, 41BB, or CD137, the CAR T cells can show different functional properties. CARs used in the most clinical trials directly target CD19, which is an antigen expressed on the majority of B-cell malignancies. To treat acute lymphoblastic leukemia and non-Hodgkin lymphoma, FDA-approved Kymriah and Yescarta are the two treatments which both target CD19. When SCFV of CARs binds to CD19, activation signals are passed through intracellular domains. Activated CAR T cells will undergo T cell proliferation and induce cytotoxicity of tumor cells.
There are several generations of CAR T cells, with each new one engineered to be more complex and effective at its job. The first, most basic generation consisted of only one CD3 zeta chain and an intracellular domain. There are no bells and whistles with this generation, and because of its simplicity, it could not produce enough interleukin 2. The treatment then had to be supplemented with exogenous IL-2. There is also not enough CAR T cell proliferation and short in vivo survival, which called for some changes to the therapy. To address the issues of the first generation, the second generation utilized co-stimulatory signaling to increase T cell proliferation, cytotoxicity, and the in vivo half-life. Depending on what the co-stimulatory domain was made of, the outcome of the treatment would be different. Studies have shown that one composition resulted in premature CAR T cell exhaustion, while another composition resulted in activation of the CAR T cell even without the presence of the target antigen. Because of that, the third generation aimed to better the co-stimulatory domain composition. This was accomplished by mixing several co-stimulatory domains inside the endo domain. Despite the changes in the therapy, Generation 3 was no more efficient than Generation 2. Since this attempt was unsuccessful, the fourth generation was based off the blueprints from Generation 2. The difference here is the introduction of transgenic proteins like cytokines. This generation can also be referred to as TRuC CAR T cells, which stands for T cell redirected for universal cytokine mediated killing. When the transgene is expressed at the tumor location, it increases the efficacy of the mechanism while minimizing systematic toxicity. The fifth generation of CAR T cells is currently in the works with a primary focus on the JAK-STAT pathway. So now let's talk about how CAR T cells are made. Several days prior to the process, a weakened version of chemotherapy is usually administered to the patient in order to lower the count of immune cells. This is called lymphodepletion and it is done to facilitate a less competitive environment where the CAR T cells have the best chance at fighting cancer. The patient's blood is then drawn and subjected to leukapheresis to collect mononuclear cells. Then the T cells are separated from the leukocytes, and all T cell subsets of CD4, CD8 composition are separated. Success of the treatment has been found to be in part influenced by the stage that the harvested T cells are in. In cultures with very controlled and specific conditions, T cells are activated and polarized to be a specific phenotype. Retroviral or lentiviral vectors are commonly used during the transduction step. When activated and modified, the T cell successfully expresses the inserted transgene that can encode for a tumor-specific CAR. Then, expansion must occur to obtain the necessary amount of cells for treatment. Once the product is properly created and approved for use, the cryopreserved CAR T cells are thawed and then infused back into the patient to treat the cancer. Now let's talk about how CAR T cells kill the cancer once they're infused back into the body. When the CAR T cells interact with the specific antigen on the cancer cell through a single chain variable fragment recognition domain, it is activated. Upon activation, signaling proteins called cytokines alert other parts of the immune system to report to the cancer cell, which causes inflammation and subsequent cell death. Most people stay in the hospital for a week to 10 days and are monitored after their treatment. Of course, this treatment is not 100% perfect, and there are a few side effects. One side effect, called cytokine release syndrome, or CRS, occurs because the immune system reacts to CAR T cell multiplication and the concurrent cytokine release into the blood. Breathing difficulties, rapid heartbeat, fatigue, fever and chills, changes in consciousness, and vomiting or diarrhea are all physical manifestations of CRS. Another issue is on-target, off-tumor toxicity. CAR T cells may target antigens on healthy cells because while tumor-associated antigens are present on cancer cells, that they can also be present on the surfaces of healthy cells too. There are also several neurological symptoms from neurotoxicity that a patient may experience too. This includes aphasia, confusion, seizures, twitching, and balance issues, to name a few. Due to the severity of all the potential side effects, patients are typically required to stay at the hospital for 7 to 10 days post-procedure so that they can be closely monitored. After that monitoring period, patients are recommended to have someone with them all day for an entire month and to always stay within driving distance of their treatment facility. Driving is also discouraged for about 2 months. Another side effect, albeit not as common, is B-cell aplasia. This happens because anti-CD19 kills CD19 expressing B lymphocytes, and as a result causes a mass decline in B cells. The success rates for CAR T cell therapy varies from study to study, cancer type to cancer type, and from short-term to long-term recovery. One study on children with acute lymphoblastic leukemia showed immediate post-treatment remission in 85% of the individuals, 60% of whom would later achieve 12 months of remission. Another study reported the long-term remission rates for CAR T cell therapy was about 30 to 40% success. One other study in chronic lymphocytic leukemia and non-Hodgkin's lymphoma had a remission rate of 35 to 70%, with only a third of those people achieving long-lasting remission. Lastly, a decade-long study showed that CAR T cells were still detectable in patients for over 10 years post-infusion with long-lasting remission. Prognosis of patients who experienced unsuccessful CAR T cell therapy is not good. T cell failure can occur for a number of reasons, including loss of target, trogocytosis, selection pressure, and T cell exhaustion. There are also several limitations and challenges that come with this way of treating cancer. One big issue is cost. The most recently FDA-approved version of CAR T cell therapy costs over $450,000 for the patient and upwards of $1 million for healthcare providers to treat them. Of course, this number depends on the patient's insurance coverage or if they qualify for Medicare. The long-term survival rate is also not as good as some other long-standing options, such as chemotherapy and radiation. There are several possible explanations for why CAR T cell therapy may not work for some individuals. The new CAR T cells might not activate or multiply in the blood. T cell exhaustion can occur, or the cancer can mutate so that the CAR T cells no longer recognize the antigen. With less than half of treated patients achieving long-term survival status, there's a long way to go in terms of improving the long-term efficacy of the therapy. There are also reasons why T cell collection may be difficult. Some of these reasons being old age. The patient has gone through several cancer treatments in the past, thrombocytopenia, and a couple other reasons. Taking a look into the future, this type of cancer treatment has a promising outlook. As of March 2020, there were more than 800 studies on CAR T cell therapy. While it is currently predominantly used to treat cancers of the blood, newer studies are aimed at testing the efficacy of CAR T cell therapy on solid tumors. Current efforts also aim to minimize the amount of and severity of side effects, while increasing remission rates and durations and improving CAR T cell production so that patients are treated as soon as possible. In terms of making the therapy safer, one treatment from the company Cellectis is currently in phase 1 trials and is testing a switch control system which only turns on the CAR T cells when the patient is given a specific drug. Another pharmaceutical company is working on something similar, but for solid tumors, where the CAR T cells are activated upon administration of the drug Remidusib.